Okay, so here's our lecture for the child with the genitourinary condition. This is going to be chapter 35 in your book. So we are going to first review some anatomy. So our urinary system, we have 2 kidneys, 2 ureters, the urinary bladder, and then the urethra. Genital-wise, so our reproductive organs are with our male children, we have the prostate, testicles, epididymis, and then for our female children, we have a uterus, fallopian tubes, ovaries, external genitalia, and then the perineum. With our genitourinary system, that includes our urinary and reproductive systems. This system is going to process and eliminate our waste from our blood, so it acts with the waste elimination through filtering our blood through the urea and the creatinine. It regulates our body fluids, the acid-base balance, and reproduction. So we have our homeostasis, that's going to regulate our fluid balance, electrolytes, and then that acid-base equilibrium. And then the reproductive role that is going to support reproduction through development and function of genital organs. So next we're going to move to the common pediatric genital. We're just going to say GU because I keep tripping up on that word. So our urinary tract infections, our UTIs, these are often caused by a bacterial invasion, so commonly E. coli, and this is just going to be from like poor wiping practices from the perineal area up to the urinary tract. Risk factors is going to be poor hygiene, urinary stasis, and congenital anomalies. For our untreated UTIs, we want to remember that this can progress, so it can move to pyelonephritis and cause kidney scarring. Our hemolytic uremic syndrome, so HUS, the definition of that is a triad of hemolytic anemia, thrombocytopenia, and acute kidney injury. The cause is often going to be following an infection with E. coli again, that's going to be producing that Shiga toxin. So the significance of this, this is the leading cause of acute renal failure in children, and we're going to be managing by supportive care, so fluids, dialysis if needed, but with this, antibiotics are usually avoided. Lastly, we have our glomerular nephritis. That the definition is inflammation of the glomeruli, usually post-infectious, so commonly after a group A strep or skin infection. Clinical features of this is going to be the hematuria or tea-colored urine, proteinuria, edema, and hypertension. Management of this, we're going to be supportive, so fluids or fluid and salt restriction, antihypertensives, and sometimes they'll use corticosteroids. So I just want to emphasize that our UTI, our HUS, and then the glomerulonephritis, these are our most common for the children. So each of these is going to link back to our kidney's essential role of the filtering, regulating, and then protecting the body. Okay. So our GI system begins to produce, or begins during the 11th and 12th week of fetal development. I wonder if on that slide they meant to put GU, because that really does not make sense. Okay, so by the 13th week, the kidneys are starting to produce urine. The mesoderm tissue is going to be forming reproductive organs. And then our immature kidneys are going to produce larger quantities of urine with lower specific gravity. So they're going to be less efficient. Our immature kidneys in infants and young children, they have less developed nephrons and tubular function, so they can't concentrate the urine as effectively as adults. So I just want to make the key points here. Our urine output is going to be larger quantities of more dilute urine. So that's going to have a lower specific gravity. And then our kidneys are just going to be less efficient at excreting the solutes and the waste products. Okay. So this kind of loops us around to why dehydration occurs more quickly in children, just due to that high urine output. Okay, so think of your infant kidneys as just being leaky filters. So they're going to let go of more water and not hold on to solutes as well. Okay. Here we're going to be looking at the functions of the kidneys. So um, they're going to be eliminating liquid waste products, so filtering blood through the glomeruli and tubules. Our waste products are going to be the urea, creatinine, and ammonia. This is going to help prevent any toxin buildup. Next is going to be that they produce the erythropoietin. Erythropoietin can be abbreviated EPO. So that's going to be a hormone made in the kidneys that stimulate bone marrow to produce red blood cells. So like whenever we are hypoxic, our body's going to release more erythropoietin and increase that red blood cell production. So things like chronic kidney disease, that's going to, if you have that, you'll develop anemia because of the decreased erythropoietin. Okay. They produce renin, so that brings us back to that renin, angiotensin, aldosterone system. Renin is an enzyme that is secreted by the juxtamedullary cells in the kidneys, and that's going to help to regulate our blood pressure and sodium balance. Okay, so they regulate the fluids and electrolytes, maintaining that proper balance of the sodium, potassium, and phosphate. It adjusts our urine concentration to conserve water when we're dehydrated, and then if we're overloaded, it helps to excrete excess fluid. It regulates our acid-base balance. I'm getting tripped up on these words. So the kidneys excrete hydrogen ions and reabsorb bicarbonate. So this helps our blood to maintain a normal pH from 7.35 to 7.45. Okay, I would know your normal pH range. So kidney impairment can cause metabolic acidosis. Okay. So overall, just think of your kidneys as like multifunction organs. Okay, they have many roles. They're the trash collectors, the builders, the balancers. They do it all. Okay, so our infants have a higher risk for dehydration than adults. We kind of touched on that a little bit already. But our infants, they have more of their body water held in their extracellular compartments. So as that fluid is turning over quickly, infants start to lose fluid more rapidly during illnesses like vomiting, diarrhea. They have a larger total body surface area to weight ratio. So this leads to a greater water loss, and that's making heat and fluid regulation more difficult. So just overall, they are less efficient at concentrating the urine. So again, our signs of dehydration in an infant, it's going to be that sunken fontanelle, poor skin turgor, dry mucous membranes, decreased urine output, irritability, lethargy. So just be sure to monitor fluid status closely and replace fluids during illnesses. Okay. So the infant metabolism versus the adult, our infants have higher metabolisms to support their rapid growth. This requires more water to remove the greater quantity of waste product, which leads to the more insensible water loss. So our body electrolytes, the sodium, potassium, and calcium shifts are common in our sickly infants. It wasn't a good word to use, but I got tripped up. So think of like your kids that are chronically ill, okay? Their electrolyte imbalances are going to be more drastic and common. So even mild imbalances can cause significant clinical problems. So think about like your arrhythmias that can cause seizures, altered mental status. So we're going to treat these by electrolyte replacement. A lot of your hospitals will have protocols, so you don't have to call like the doctor for orders. The doctor will put in an order set. So if your kid's potassium comes back at 3.2, you'll just match it up. I know that Epic does this. It just kind of tells you your patient's potassium is 3.2. You're going to give this many milli equivalents over this amount of time. So it kind of just, it fires orders for you. It's very user friendly. I like it a lot. So we want to be cautious with giving electrolyte replacement and making sure that we are doing it calculated on our child's weight. So making sure that you have current weights in. Okay. So for example, we have a child with diarrhea and vomiting. That's going to result quickly in dehydration and electrolyte imbalance because of the rapid metabolism, the high insensible water loss, the immature kidneys, and the large extracellular fluid shifts. So just think that infants have a high turnover system. Okay. Our body electrolytes, going a little deeper into things. So our sodium is going to be the main cation of extracellular fluid. It's going to help regulate the osmolarity, which is going to control our fluid balance and the movement between body compartments. So with hyper with an E, hypernatremia, we're going to have the dehydration, excessive sweating, and inadequate fluid intake. We can develop it from those. And with the hypo, with an O, this is often going to be from excess water retention. So the SIADH, and then heart failure over hydration. Okay, so both of these, I just want you to recognize that they are critical imbalances that can lead to neurological changes, confusions, and seizure. Okay, then we move on to the potassium. This is going to play a role in our neuromuscular excitability, so our normal nerve conduction, muscle contraction, and heart rhythms. This is going to be the main intracellular cation, so most of our potassium is going to be held inside of our cell. Clinical note on this, both our hypo and hyperkalemia can cause dangerous cardiac arrhythmias. Alrighty, our magnesium, that's going to regulate our nerve transmission and muscle contraction. So it's important for our enzyme activity and energy metabolism. Important thing with that is our imbalances in magnesium can cause muscle weakness, tremors, seizures, and then that torsades de pointes again. Phosphorus, that is going to work with our calcium. For bone mineralization and strength, but it's also critical for our ATP production. That's going to be what provides energy for our cellular metabolism. The note for this is hypo with an O, phosphatemia, hypophosphatemia can lead to muscle weakness and respiratory failure, while the hyperphosphatemia, that's a hard word to say, but so whenever you're up, the hyper, that's going to be linked to kidney disease and low calcium levels. Alrighty, last electrolyte, our calcium, that is going to help regulate our cell permeability. So it's going to control how easily our ions and nutrients are moving in and out of our cell. It's going to support our clotting cascade, so that's necessary for several of our steps in the blood coagulation. And then it's also going to determine the bone and teeth health. So the majority of our body calcium is going to be stored in our bones and teeth, helping to maintain that strength and structure. So with hypocalcemia, that is going to cause neuromuscular irritability. So that tetany, tingling, muscle spasms, seizures, and can cause a prolonged QT on your EKG. The hypercalcemia, that can cause muscle weakness, kidney stones, constipation, and then a shortened QT interval. Alrighty, so moving to our acid base and renal regulation. These were really hard concepts for me. to get. So for acidosis, meaning that our acidity is up in our blood and we have a low pH. Okay. So we can compensate with our respiratory system or our renal. So respiratory compensation is going to look like our lungs increasing breathing. So our we'll hyperventilate to blow off the excess carbon dioxide. So we hyperventilate to blow off excess CO2, and that's going to reduce our acidity. Renal compensation, our kidneys are going to retain bicarb. So that's our base, and that buffers the excess acid. So your lungs are going to be, let me collect my thought for a second. Okay, so see, I told you this still gets me tripped up. It shouldn't be that hard, but it is. So respiratory system, we are going to blow off our excess CO2. And then with our kidneys, we are going to retain bicarb. That's our base to buffer. So I always just think bicarb, buffer, base. With alkalosis, so that decreases the acidity in our blood and increases our pH. Okay. I think it would be easiest if I made this kind of into a table because I need a table to explain it to myself. So that would probably be good to post. I'll put that in the urinary system on Blackboard. So alkalosis, we have a decrease in the acidity of our blood. So there's going to be a high pH. So respiratory compensations, we are going to start breathing slower. So we'll have hypoventilation to help retain that CO2, and that's going to drive up our acidity. Our kidneys are going to compensate by excreting, so releasing bicarb, and that helps to restore the balance. Okay, so key point of this, it's hard, but our respiratory system is going to be our quick acting compensation, and then our kidneys are going to act slower, sometimes days, but it'll provide a more long-term correction. Okay. Here we go. Let me find this. Alrighty. So fluid maintenance requirements. We want to keep our fluid levels balanced for our normal body functions. For a fluid deficit replacement, we want to restore those fluids that are lost from things like dehydration, bleeding, vomiting, diarrhea, and then our ongoing fluid losses. So additional replacements needed when there are continuous losses, and some of these, I think you would be surprised whenever you have somebody hooked up to like an NG suction, like that continuous, even though it's a low suction level, you're dumping out quite a bit. You can be. So things like the NG suction, burns, you lose quite a bit, and then diarrhea. So there is a fluid calculation. I think it's going to be harder to explain this and just better to write it down so you can see the actual calculation. But it's called the Holiday-Seeger method. So look, I'll just make kind of a little hand-drawn thing and put that in with the alkalosis acidosis table, and then this calculation. I think that's just going to be easiest. Okay, and then of course there is the water intoxication, so our overhydration. This can be associated with severe mental illness, low cognitive function, extreme thirst. So I want you to recognize that with these. You can get the headache, nausea, confusion, seizures. It can lead to coma. We can have fatal water intoxication, okay? So that can also cause pleural effusions and hyponatremia. So this can be seen in kids, like whenever they're out running and they just chug and chug and chug after. Athletes can end up with this sometimes. So that's kind of why that the whole concept of like Gatorade, that electrolyte replacement, to balance and combat against that water intoxication. Okay, so our urine output for our infants, 1 gram of urine, so weighing the diaper, 1 gram of urine is going to be equal to 1 milliliter of urine. Okay, I think that would be a good math question. Okay, so remember that formula. It's pretty easy. It's a 1-to-1. Alrighty, so these are showing our average urine outputs for different age groups. Okay, I'll let you look over those. I would have a roundabout idea of what to know. So just knowing that your adolescents, they're going to put out higher volumes. Okay, more of your like adult size volume. Okay, I want to point out that for the labs and diagnostics, you have a table in the urinary section on Blackboard, and it kind of tells you just what the test is, what it's for, what you need to know. Okay, so I am not going to test you on any numbers. Okay, the only numbers you're going to see, they're going to have a normal next to them. So you'll have your normal range, and then you just got to know what, if it's elevated, what's that mean? If it's, low, what's that mean? Okay, so do not focus on studying your normal values. Okay, so just kind of a quick overview of these. Our urinalysis, that's going to evaluate our urine for color, clarity, pH, protein, glucose, ketones, and presence of bladder infection. Okay, so that can measure our white blood cells, nitrates, leukocytes. This is going to be our first step so our first line of testing when detecting a urinary tract infection, kidney disease, or metabolic conditions. Our urine culture and sensitivity, that is going to identify the specific bacteria that's causing the infection. Then our sensitivity testing, that's going to determine which antibiotics are going to be most effective. Okay, the specific gravity of, that's going to be, we have our normal range, and that's going to reflect our urine concentration and the kidney's ability to conserve or excrete water. Okay, so a high specific gravity means that you're dehydrated, you have concentrated urine, and then a low specific gravity is talking about overhydration and impaired renal concentrating ability. Next is the intravenous pyelogram. So this is going to be where you have an x-ray of the urinary tract after injecting contrast. So it's going to detect structural abnormalities. Sometimes doing this, I get so tripped up. Okay, so structure abnormalities, stones, tumors, and obstructions. We use this less now that there's like CT urography. The voiding cystourethrogram, that's an imaging test with contrast as well. While the patient voids, this is looking for any reflux, so backflow of urine into the ureters and kidneys. Okay, so this is common with kids that have recurrent UTIs. Our blood urea nitrogen, our BUN, that's going to be elevated whenever we have any renal dysfunction, dehydration, GI bleeds, and high protein intake. It's going to be decreased in our liver failure and malnourished. Our serum creatinine, that's going to be more specific than our BUN for our renal function. It's going to be elevated when there's renal impairment. The creatinine clearance, that's going to compare the creatinine in the blood versus the urine over 24 hours. So it's the best estimate of our glomerular filtration rate. A decreased clearance means that we have kidney function impairment. Okay. Alrighty, we have some clicker questions, but for the sake of time, I'm going to move on to the dehydration. Okay, so dehydration occurs when we have fluid intake that is significantly reduced. This causes loss of water and electrolytes. So hypovolemia can occur. Leading cause worldwide of this is going to be gastroenteritis or vomiting and diarrhea. that rapid fluid and electrolyte loss from our stool and emesis. Next is going to be fever and sweating. So children are more vulnerable for this due to that high surface body area. High surface body area to weight ratio. Okay, so the hypovolemia, if untreated, we can have circulatory collapse and shock. So we want to evaluate dehydration. So measure and record their intake and output. And inadequate fluid intake is very common with our children when they're ill because they refuse to drink. They have some difficulty swallowing from a sore throat. The other things that kids may have this with is so certain things like diabetes can cause our children to urinate more. Certain medications can cause them to urinate more. Heat exposure, excessive physical activity. So just note that our infants and young children are at a higher risk because their higher metabolic rate and the immature kidneys make them just less able to conserve water. Okay, so evaluating this dehydration, we want to obtain a daily weight and compare it to our baseline. What you're going to look for at these children, looking for dry skin, poor tissue turgor, dry mucous membranes, a sunken fontanelle, sunken eye sockets, pale skin and poor perfusion, delayed capillary refill, hypotension, a decreased body temperature, rapid pulse, tachypnea, lethargy, a weak cry, and just poor muscle tone overall. Alrighty, interventions for this, oral fluid replacement if possible, but we're going to give IV fluids like normal saline boluses and for our moderate and severe dehydration. So nursing considerations with the dehydration, when possible, we want to orally rehydrate, okay? So if the IV therapy is required, we want to, getting an IV for a kid is a pretty upsetting thing. So if we can coax them into taking PO, so even things like popsicles, it's liquid intake for kids. Sometimes when kids get just that refusal, they can require a PICU admission. But I like using the popsicles just because if they're refusing to drink because of a sore throat, that can help be soothing as well. So moving on to the common genitourinary disorders. So we have our UTI. This is going to be one of our most common childhood bacterial infections. So it can be located in 3 areas. When it's in our bladder, it's cystitis, the urethra is urethritis, and then the kidney, it's going to be pyelonephritis. This is going to be caused from that urine refluxing back up into the ureters, incomplete bladder emptying, or just not wiping correctly for the kids. Okay, so we will diagnose this by the frequency, urgency, and the pain with urination that they report. We'll look at the odor, color, and clarity of the urine, assess if there's been any fever, look for signs of dehydration. Whenever we do get a urine sample on them, look for that hematuria and then the low pH. Ask the parent about any lethargy, poor feeding, and then also a history of UTIs. That's an important thing to know if there's a history. Okay, so our intervention, we're going to provide PO fluids if they will, maintain a patent IV, that's a trick, treat our fever and their discomfort, administer antimicrobials as ordered. Nursing considerations, we want to educate about prevention techniques. You will find that there are some parents that do not know about correct wiping, so don't assume that they know. It doesn't hurt to go over basic teaching and you can go over it with the child to kind of indirectly also teach the parent. So teaching your family about prevention strategies, proper wiping front to back, avoiding bubble baths, wearing cotton underwear, not sitting in wet bathing suits for a long time, and then encourage regular voiding. Okay, sometimes little kids, they get to where whenever they are toilet trained, they're outside, they're playing, going off, and they hold it for way too long. So just encourage regular voiding, adequate hydration. Sometimes constipation can also contribute to UTIs in children. So we want to encourage a high fiber diet. And then just also understanding that sometimes your kids can have pretty non-specific symptoms like fever, irritability, poor eating habits. Alrighty, so enuresis, this is going to be a voiding dysfunction, so our nocturnal incontinence, so our bedwetting as a common name. This is going to be the most common form. It's going to be involuntary voiding at night after completing toilet training. Okay, so the diagnosis for this, we are going to just do a thorough medical exam and health history with the parent, assess if there's been any UTIs, take a urine sample, look at any structural abnormalities, neurological conditions or behaviors, environmental causes that could be causing this. I also want to note that there is the daytime incontinence. So when we have like kind of wishy-washy toilet training, and what I mean by that is like inconsistent, we can have the diurnal incontinence. So we want to kind of drive home with the parent that this is pretty upsetting for the child, whenever they do have the toilet training and they're having these accidents. So we want to focus our nursing care on the promoting a healthy self-esteem for the child, focusing on their support, the reassurance, and then educating the family on bladder training. Okay. Interventions, reassure and educate your parents. Fluid restrictions after the evening meal for younger children, motivations, alerts, and there also are medications that we can give older children whenever this continues. The medications we can use are desmopressin and anticholinergics. So that's going to be if our bedwetting alarms, if those fail, there, sticker charts for our younger kids. So just be empathetic, have a non-judgmental approach about it. There's, it is usually not a behavioral problem. So be understanding of that. Okay, it's a developmental concern. It is not simply a behavioral issue. Okay, next is going to be nephrotic syndrome. So I think you are going to see a question in the near future about this one. Nephrotic syndrome, the development of pores along the final filtration membrane of the kidneys and subsequent loss of serum proteins. So we're going to have this abnormal protein loss, especially albumin. That's going to be leading to the proteinuria, hypoalbumin, edema, and then the hyperlipidemia. So there's no single known cause of this. It's usually a genetic factor that affects your glomerular permeability. So this usually is responsive to corticosteroids. If it's a primary childhood nephrotic syndrome, if it's a secondary nephrotic syndrome, that could be from lupus, infections, diabetes, or certain medications. Okay, so I want you to know your cardinal symptoms. There we go. We are going to have severe proteinuria, our hypoproteinemia, I can't say that one, That's going to do with our albumin. Hyperlipidemia and edema, it is usually periorbital edema, wink, wink, okay? Diagnosing with this, the most common thing that people notice is that you have really foamy urine, okay? It's really frothy. You can have fluid accumulation and then that ascites going on, the weight gain in the abdomen, as well as the fatigue and decreased appetite. So you have this classic tetrad of the proteinuria. Well, this is your classic. Okay, those are your symptoms to look for, and just know the foamy urine. Okay, and next is diagnosing this. We can do this. So when we have a lot of edema with our GI tract, we could have diarrhea. So if they report diarrhea, high blood pressure, and that's going to be related to the fluid retention. Our interventions, it's going to be supportive. So the corticosteroids are often the first line. Diuretics can be used for the edema, albumin infusions, diet modifications. So that's going to look like low sodium, adequate protein intake. The nursing considerations, we want to provide emotional support for this child and educate their family on how to cope with this. So monitoring their vitals and the skin integrity. We would see issues with the skin integrity from the edema. Okay. I do have written down on here from, I think, the ATI book remembering the classic complications of nephrotic syndrome are going to be, the complications, infection, clotting disorders, and malnutrition. And that will help kind of lead you back to your cardinal symptoms too. Okay, so here we have a picture. I need a drink. Okay, so this is going to look at kidney damage. So our glomerular filters, those tiny little capillaries, they become leaky. And instead of keeping the protein or the albumin in the blood, it's going to let it just dump out into the urine. And that we can detect this by just the dipstick test. Okay, and that'll show the proteinuria. We can have low protein in the blood when we have a lot of it lost in the urine. So there's a lot less left in the bloodstream. Okay, so we have this fluid shift where we get the edema. So we're moving here now. We have this fluid shift where there's not enough protein to hold the fluid in, so it's going to leak out of the vessels into the tissue, and that's going to cause the edema. And it's most commonly seen in the face, so that periorbital edema, the ascites around the abdomen, and then they can also have edema in their legs. So just kind of remember that we have the leaky filters that are leaking out the protein, which leads to the which leads to the proteinuria, leading to the low blood protein that's causing the fluid leakage, giving us edema. Whew. Okay. Alrighty, we're getting towards the end. All right, we got that acute glomerulonephritis. This is going to be a disease of the glomeruli, so our kidneys filtering units. This can be following a severe infection. Most commonly, this is going to be post-streptococcal infections. Okay, so something like strep throat or impetigo. So the immune response from this infection damages the glomeruli, leading them to become inflamed and less effective at filtering blood. Our characteristic symptoms that we're going to see is the tea-colored urine, or can be sometimes called Coke-colored urine. That's going to be showing our hematuria or proteinuria, but it will be less severe than the nephrotic syndromes. Edema, again, it's going to be that periorbital, and then hypertension as well. We're going to diagnose this through cultures, urinalysis, a chest x-ray, and then renal ultrasound or biopsy if needed. So we can move on to our interventions and nursing considerations. So interventions, we want to prevent fluid overload and build up of further waste products, so limit fluids and sodium intake, administer diuretics if needed. These are kids we want to get a daily weight on, monitor their urine output. We're going to get labs on these kids, monitoring their BUN and creatinine, adjusting their diet if needed. Nursing considerations, so checking with the parents or caregiver if they've had any history of infections. So be sure to ask about like sore throat, any skin lesions, recent illnesses. Systemic systems we would see is the edema, so managing that, the hypertension, and the fatigue for the child. We want to watch for complications such as acute kidney injury, seizures, and pulmonary edema. Okay, so your nursing care is going to focus on monitoring fluid, electrolytes, blood pressure, and infection. Okay, we are getting to the hemolytic uremic syndrome, so HUS. This is rare and potentially lethal, a potentially lethal form of kidney failure. One moment. Okay, I had to take a break for a minute, so I don't remember what I said on this slide, but it's a rare and potentially lethal form of kidney failure that's caused by bacterial infections. We base this off of the triad of the hemolytic anemia, thrombocytopenia, and acute kidney injury. Okay, so interventions for this PICU admission is often required for close monitoring. Supportive treatment is going to include IV fluids for hydration, correction of electrolyte imbalances, management of anemia, and pain and comfort. So antibiotics can be used in some cases, but not always recommended depending on the organism. Okay, so I have a little note here that some antibiotics can worsen the toxin release from E. coli infections. With our very severe cases, our child may require dialysis if the renal failure progresses. So I want you to know that HUS is strongly associated with bloody diarrhea followed by acute kidney injury in children, okay? This is going to be one of your medical emergencies that requires early recognition and aggressive supportive care. Okay. So going on to the nursing considerations, we want to provide education and emotional support for the family and the child, and observe for any further complications. For our congenital urinary anomalies are, I'm going to try this here, vesicoroidal reflux. That's our most common GU anomaly. This is where our urine's going to flow back into the ureters and sometimes into the kidney. That causes the risk for recurrent UTIs and kidney damage. It can be graded 1 through 5 depending on severity. Our management's going to include prophylactic antibiotics for the recurrent infections, monitoring our renal function, and surgical correction in severe cases. So again, teaching our parents about UTI prevention. This has been mentioned a ton throughout here, so I would know good UTI prevention. Importance of follow-up imaging, medication adherence, and recognizing signs and symptoms of infection early. Alrighty, we have the exstrophy of the bladder. So this is whenever a child's born with an exposed or open bladder on the abdomen. It's going to appear as a red mass and continuously drain urine. we can diagnose this just by the inspection and palpation of it. Interventions. That does not make sense. Okay, because these, I don't know why that says interventions, because these are like conditions on their own. So hypospadias, that's going to be an abnormal opening on the underside of the penis. So often in the glands, the shaft or near the scrotum. So this can cause difficulty directing the urine stream. It can be associated with chordee, so the curvature of the penis, and it can interfere with fertility as well. So these are usually surgically corrected, often between 6 to 12 months of age, but you want to avoid circumcision before the repair, okay, because sometimes they'll go back and use that foreskin for grafting. We want to educate the parents about the timing of the surgery, and then post-op maintain catheter, stent placement, prevent infections, and manage pain. When I worked in PACU, these kids usually did not come back out with catheters. So it was kind of like a same-day surgery kind of thing. But we want to know how to teach families good catheter care. Okay, the epispadias is the urethral opening on the dorsum, so the top of the penis. This is often associated with that bladder exstrophy, so whenever the bladder is located outside of the abdomen wall. This can affect the urinary continence and then later the sexual function if untreated. So we want surgical repair. It's often done in several procedures, so it's a staged thing. It can involve bladder neck reconstruction and urethral repositioning. So we want to be supportive of the parents and the child, provide wound and catheter care post-operatively, and then teach them the long-term monitoring for urinary functions and signs of infections. Okay, so we have a couple of the genetic or congenital reproductive system differences. So intersex condition, this is going to be atypical physical sex characteristics. So there are variations where an individual is born with atypical sex characteristics, so chromosomes, gonads, and genitalia that just typically don't fit typical male to female definitions. So this can involve a difference in hormones or reproductive anatomy, external appearance. Management can include medical, surgical, psychosocial, but best current practice is to emphasize the individualized patient-centered care and avoid unnecessary surgeries in infancy. And Turner syndrome, that is going to be a chromosomal condition that affects girls born with only one X chromosome. So clinical features of this, they'll have short stature, underdeveloped gonads and ovaries, and this will often result in infertility and lack of spontaneous puberty. So possible health effects from this could be heart defects, or not effects, it's not going to cause it, so possible associated health issues, heart defects, kidney abnormalities, certain learning difficulties. We manage these with growth hormone therapy and then estrogen replacement therapy. Okay, so this is going to be kind of a lifelong thing. Next, we have Klinefelter syndrome. This occurs whenever there's an extra X chromosome, so we have that XXY. So this is going to be a physical, or the physical and developmental effects. They'll have tall stature with long legs, small testes, reduced testosterone production, delayed or incomplete puberty without treatments, gynecomastia, so that's breast development in males. They can have some cognitive and behavioral disabilities. It says especially with language and reading. They're often socially immature, impulsive, at an increased risk of anxiety and depression. So management of this is going to be long-acting testosterone therapy to help promote the male secondary sex characteristics, increase muscle mass, deepen the voice, and then improve overall bone health. Okay. So again, this is going to be a lifelong hormone replacement. Alrighty, acquired reproductive sex disorders. So with children, sometimes we can come across foreign objects in the vagina. It can be accidental, kids just putting stuff somewhere. It can be, small toys. It could be little wads of toilet paper, just small objects. It can be accidental or intentional. So we always want to evaluate for any possible abuse whenever we find a foreign object. We want to rule out any mental health conditions that might cause this. But we want to remove the object for the prevention of infection, things like toxic shock syndrome. Okay. Pediatric vulvovagina. I can't say it. Okay, so this is going to be vaginitis from fungal infections. So your candida, poor hygiene, irritants, so things like certain like fragrant soaps, bubble baths, tight clothing, wearing swimsuits, wet diapers for a long time. So it'll be red, itchy. You can have discharge. It's just overall uncomfortable for the kid. So we can manage that by teaching improved hygiene techniques, using an antifungal or antibiotic therapy if an infection is confirmed, and avoiding irritants. Then there's labial adhesions. So these can be partial or complete adherence of the labia minora. Causes of this could be scarring from surgical procedures, complications from female genital mutilation, poor hygiene, trauma, burns. So this can cause difficulty with urination, pain. It can cause recurrent infections. Usually you will use a topical estrogen cream. Okay. They'll try to use the estrogen cream for a while, and if that's not kind of causing like a separation from that adhesion, they can go in and surgically separate. Okay. Acquired reproductive system disorders, so sexually transmitted infections. So our adolescent population is going to be at the highest risk for this due to factors of unprotected sex, multiple partners, just plain lack of knowledge about prevention, and then limited access. So whether that's money, embarrassment, just lack of access to healthcare. So we want to, on our assessment, just ask non-judgmental questions just about their overall health and sex history. And then we can include topics on that like contraceptive use, any prior STI testing, condom use, educating on symptoms. Okay, we want to use developmentally appropriate language and ensure privacy. Okay. So we want to, for our nursing considerations, encourage routine screenings if they are active. So we have a question at the end here. If you have any questions, because we also have the answer along with it. But I want you to reach out if you have any questions about this lecture. You can reach out to me between 11 and 12 on that Teams link that I'll send out, or you can contact me because I won't be at in-person office hours. Okay, but you're always welcome to contact me if you have any questions, whether it's on this topic or stuff that's been previously covered. Okay, so I'll move on to the adult.